You know very well, February is American Heart Health Month. And I thought that this would be such a cool time to highlight the connection between reproductive health and cardiovascular health. We work together on so many different patients and just the care of women throughout their reproductive lifespan. But I think it's really important for everyone to understand and realize the connections between your reproductive health and cardiovascular health and how they can influence each other. You know, there are cardiovascular factors that can impact your reproductive health both before, during, and after pregnancy, and just have impact for your overall pregnancy outcomes and your long-term health. And so we wanted to just talk a little bit today about what some of those risk factors are, how we evaluate, treat them, and what are the things that we want women to know about this connection. So can you tell us about a little bit about some of those most common cardiovascular risk factors that you see? I know the ones that I see most frequently are obesity, high blood pressure, diabetes, but please tell us how that kind of can impact overall health care and how you see that showing up in women's health when they come to your office.
Absolutely. So I think one of the biggest things we want to highlight is the same cardiovascular risk factors that affect your health overall, with or without being pregnant, affect pregnancy outcomes, and then go on to affect your long-term health. So when we think about risk factors we want to focus on, we're thinking about the AHA, American Heart Association, top 8 risk factors. So they're the common things we always harp on, but we want to really highlight them more this month, especially. So those would be maintaining a healthy diet, maintaining physical fitness, maintaining your weight, your blood pressure, your cholesterol management, your glycemic control, trying your best not to be a smoker or quitting if you can, as well as, and this one was a surprise for me, also sleep quality and sleep duration has been more and more of a factor in cardiovascular health, as well as how it's impacting those risk factors when you're trying to get pregnant and when you're trying to have a successful pregnancy and postpartum period.
That's so important because so many of those things actually overlap with exactly what we tell our patients before they get pregnant or in between pregnancies, in terms of increasing physical activity, modifying, lifestyle factors and behaviors like reducing smoking, and managing diet and increasing exercise. And sleep is another huge one that I think is so underappreciated in terms of how it actually impacts your overall cardiovascular health. You know, in our world, it also has a huge impact on your hormonal function, in terms of weight management and just some of those hormonal signaling between different tissues that can impact your reproductive health too. So important. You know, when we see women who've had some of these pre-existing factors prior to getting pregnant, I think sometimes there can be a sense of urgency on our end because usually when people present to us, they've already been trying to get pregnant, they haven't been successful. And so there's a significant kind of urgency to say, I want to get pregnant right away. But then they come into the office, they may have some issues with high blood pressure or cholesterol problems or diabetes that's not managed. Another thing that I see sometimes is maybe some risk factors that presented in a prior pregnancy that we want to evaluate and kind of manage before going into a new pregnancy. So what kind of like encouragement or tips or just evaluation would you give to these women who are like, I want to be pregnant today, I don't care that my blood pressure is out of range, or actually I don't want to go back on blood pressure medication, I'm just ready to get pregnant?
Yes, I think there's so much emphasis on baby and how can baby be healthy? How can we get there? And then during pregnancy, how do we make sure that baby's healthy? The best thing you can do is make sure you are healthy before getting pregnant, during, and after. I'm going to repeat it. I'm going to sound like a broken record because it's so critical. And that's what we're learning. Every piece of data shows us that. The AHA also put out this really nice schematic that shows your early childhood leads to your adolescent and young adulthood life. that helps you for your health to conceive. Everything you do in pregnancy for your own health helps not just you, but baby. And we do see that, high blood pressure, hypertension, hyperglycemia during pregnancy can affect the baby, in the short term, but also in the long term. And then it gives us a place to say, okay, this happened during my first pregnancy. How do I set up for success for my second, if I'm interested in my second? And how do I set up for long term? So you really have to look at it and not dissociate like the excitement of wanting to have a baby and start that new step in life. Don't dissociate that and say my own health kind of is on the back burner. It really helps not just you be present for your future family, but also for your baby's health, short-term and long-term. So usually what I tell patients when they come in, if you have a blood pressure issue, a weight issue, hyperglycemia, it's worth it to pause, take a second, take even a couple of months to get things more under control, because it just sets you up for success and not having that continual sort of frustration of saying, okay, again, we're just not getting to where we need to be. Taking that time for yourself sets you up.
Yeah, it's invaluable, how much optimizing your medical health prior to pregnancy can really, increase your chances of success, having a successful pregnancy, but also, maintain a good health status for you and baby during pregnancy. We talk so much about risk factors like preeclampsia, even having preterm delivery and having gestational diabetes, which occurs during pregnancy, which actually increases your risk for diabetes later in life. Some of the other things that we don't really talk so much about are, things that can happen in terms of your own cardiovascular health during the course of pregnancy or as a result of pregnancy that can happen to even the healthiest people, but certainly, someone who's had pre-existing conditions can also be at higher risk for these things like cardiomyopathy of pregnancy. So talk to us just a little bit about I have so many people that I send your way. We want to do what was called preconception, cardiovascular evaluation. What does that visit look like when they come to see you?
Yes, so first we're going to talk about each of those risk factors. What's your diet like? What are our weight goals? Are we at a healthy weight or BMI is less than 25? How can we make some changes in lifestyle and what we're eating and our activity to get there before we start trying? What's your blood pressure? So we'll check your blood pressure, we'll see your weight. Usually we talk together and we'll have some baseline labs, so we'll see how their sugars and cholesterol panel are. We talk about smoking status, and then we talk about sleep hygiene. And then outside of that, we also discuss, have you been pregnant before? Have you had any miscarriages before? How did the prior pregnancies go? What were your family members' pregnancies like? So sometimes we can see in mom, this happened. Okay, now what about my own pregnancy? And we always like to ask about congenital heart disease that runs in the family or any other familial things that may run in several generations that we should look into more, because mom can be screened for them prior to getting pregnant. It can affect how we manage things during pregnancy. But also once pregnant, hopefully we have to see, should the fetus be screened for this issue as well? And then postpartum, once they're born, is this something that needs to be looked into? So really the basis of that first visit is sort of, let's review all of these metrics of all of the cardiovascular risk factors, see where we can make targeted changes before trying, and then see during pregnancy, what do we need to address, and then afterward. And sometimes it's just as simple as let's talk about your history. Let's talk about your family history to pull out some of these issues that need to be addressed that are often missed.
No, that's so important. And thank you so much for really reiterating the importance of family medical history. We also rely a lot on family medical history to hear those kind of risk factors. Is there a cancer history? Is there significant cardiovascular, health issues? But you bring up a great point in terms of, heart disease and congenital or genetic forms of heart conditions that we can actually try to prevent in the next generation with testing that is done prior to pregnancy. So there is the ability, you know, if there's if there is a condition that's caused by a gene mutation and inherited in either an autosomal dominant or autosomal recessive fashion, then there is a way for us to actually test the embryos for those genetic mutations prior to pregnancy with a process called pre-implantation genetic testing for monogenetic disorders. And so again, making sure that, you know, you've had a thorough evaluation and thorough history is important, because if this gene mutation is identified, then we want to talk about, could we prevent passing it to the next generation by doing in vitro fertilization or IVF, and then completing PGTM to screen your embryos for that genetic mutation. So that is like hugely important. I think some people are very afraid of getting bad news, in particular about high blood pressure or about their glycemic control, or about, you know, prior experience with maybe preeclampsia or severe preeclampsia in a prior pregnancy. You know, what kind of like tips or reassurance do you give? You know, one thing I try to let them know is that we have lots of different treatment options. And so it's not so limited to, you know, just writing you off because you have high blood pressure. We have different medications we can use. We'll be taking a thorough history to understand if there are, you know, lifestyle factors that can be modified in advance. And I feel like there's a whole new world now with new medications that could be helpful prior to pregnancy, and still trying to understand what things can be kind of continued during pregnancy versus not. And so what, you know, kind of tips, hints, and then treatments do you have to offer once the patients are diagnosed in these ways?
Yes, I think in general, always encourage patients. It's better to know. It's better to know, so then we have a plan and we can move forward towards your goals. So just because you have been diagnosed with hypertension, or just because you had preeclampsia in the first pregnancy, does not mean that we can't go on to have a successful conception, pregnancy, and healthy baby afterward, and healthy mom afterward. It just means we need to be watching things much more closely, both on the REI and OB side of things and on the cardio side of things. So I think I've had many patients kind of go through the process, and that their next pregnancy goes really well. We learn from the first. We say, okay, that blood pressure tended to start creeping in the end of that second trimester. Instead of every 6-week follow-up, I'm following you up every 3 weeks. We're all messaging around. And you've got your cuff. We're making sure we're keeping active. We're watching our salt. It just means we need to have a little bit more TLC during the next time, and preparing for the next time. In addition, I think I know that everybody wants to kind of have the most natural, least intervention, least medication type of route pre and during pregnancy, but sometimes your best interest is to get all those risk factors totally under control, so that you're at the best point to move forward. For example, you know, yes, we can say, all right, I'm going to exercise, I'm going to watch my salt, I'm going to just try my best to get that blood pressure nicely under control. And we all do our best, but life comes into things, genetics comes into things, and sometimes we just can't keep our pressure low enough. And in that setting, it's better for uteroplacental circulation, for the baby's growth, and for your own health, to be on just a little bit of medicine to control things, just so we don't end up in a situation where now it's an emergency and now we're dealing with the repercussion. So in those cases, I think prevention and working on things proactively is just so much more of a controlled situation, where we know, hey, everything's under control. Yes, we're on a little bit of medicine, like maybe a beta blocker, maybe like labetalol, or a calcium channel blocker, and like nifedipine. We're on a little medicine, but we know the OBGYN is going to watch that baby's growth properly. So we're knowing that the baby's growing well, despite the blood pressure medicine. My blood pressure is great. I'm feeling well. I'm doing everything I can. You're going to end up with a better outcome than if we are struggling working without any medicine and we're still having uncontrolled pressures.
That is so, so true. And I love that message that, listen, sometimes you are literally doing the best that you can, and you still might need medication. So medication isn't like a punishment for, not doing what you need to do. Everyone's body is different. Everyone's genetics are a little bit different. And some people are going to need some medication to keep things well controlled prior to pregnancy and during pregnancy. A lot of times, when I'm asking you to see a patient, it actually is maybe they're on a medication that's not suitable for pregnancy. And how do we transition to a new medication, make sure that things still are controlled, and then, kind of proceed from there. So another reason to check in and have these evaluations prior to pregnancy is, again, getting you optimized on the best medications that hopefully you can continue through pregnancy.
Absolutely.
Let me see. I'm trying to think of other questions.
Do you guys, I obviously want to be mindful of, HIPAA and everything, but if there's like a more specific case, or if you guys want to talk about a patient that you worked with together to help them meet their goals, if you feel comfortable doing that.
Yeah, I think we can talk kind of obliquely.
Yeah, I feel like we've been just talking about like how the things go back and forth.
Yeah.
Um, I mean, I don't know, maybe some of the like proactive monitoring we've talked about. I love having the idea of like the preconception echo, or even considerations with like older parenting, being pregnant in your 40s. What changes in cardiovascular, like, physiology and pregnancy? Because you can like slice and dice some of this, Hannah, but I literally describe pregnancy as like a cardiovascular endurance event.
I
Like,
was just gonna say that.
very few
It's a stress
people
test.
would wake up and like just run a marathon if they've never done any kind of training or long distance running before. And, so many ways pregnancy is the same kind of demand on your cardiovascular system. So much has to change, so much has to be able to accommodate increased blood volume, the way that your heart has to kind of pump to get all of the blood out circulating to your body, increasing, a new organ that you literally developed called the placenta, which helps to nourish your fetus in your growing pregnancy, but also the actual baby growing itself. And so I think that having that idea, understanding, yes, pregnancy is normal, it's natural, it is something that your body could do, but it also places a huge demand on your cardiovascular system. If you, just wanted to talk a little bit about what that looks like, and, what some of those changes are in pregnancy and the postpartum period.
I think this is a huge topic because that's a perfect analogy. You can't just I mean, most of us cannot just up and run a marathon and think about how much that taxes the heart, the lungs, your whole body. Pregnancy is just the same. So many things change during pregnancy. So number one, your cardiac output goes up. It goes up in a couple of ways the cardiovascular system is altered in a few ways to support that extra blood flow to the growing uteroplacental system and downstream to the baby. So your cardiac output goes up, your heart rate goes up, your stroke volume, how much actual blood volume in the body goes up. We just literally dilate all the blood vessels in the peripheral system to, again, shunt blood to the baby, the growing baby. So that means all of the vasculature is sort of activated during this period. We also have increased blood flow to the kidneys in the mother to allow for more filtration of toxins coming from the baby and being filtered by the mother's kidneys. So all of these things just tell you that there is massive amounts of demand on the mother's own cardiovascular system. And if you imagine I was telling someone how to prepare for running a marathon or running a triathlon, we would say, okay, start like getting into shape. Like, let's start doing some cardiovascular exercise. Let's watch our salt. Let's watch our carbs. Let's watch what we're putting into our bodies. Let's quit smoking. Those are all the same things we want you to do before pregnancy to help your cardiovascular system support you and the baby through it and after. So we absolutely see that. And it's one of the true, like, it's truly a miracle of nature that our bodies are able to do that. So we want to help nature along too, by setting yourself up before.
No, that's so important. Just to shift gears a little bit, talking about, okay, someone who's maybe gone through a pregnancy, maybe the pregnancy was complicated by preeclampsia or gestational hypertension, and now they're ready to consider, another pregnancy. What needs to be done in between those pregnancies, or what kind of markers do you want to look for or check for before they plan to have another pregnancy?
Right. So super important. Let's take, for example, preeclampsia and hypertension. Super important that prior your blood pressure is nicely controlled at goal. I would target normal attention, not saying, oh, this is pretty good for your average patient. I would say we need to get to 120/80 or better prior. Because often that pressure will tend to creep as we get through pregnancy, especially towards the latter parts. We really want to make sure you are truly normal. We want to reassess. So is that normal with diet and exercise? Is that normal with medication? And what medications are you taking? For sure, we need to then transition. Some medicines are not appropriate for pregnancy, and they can be, there's risk of birth defects or other issues for the baby. So we need to then transition you onto new medication that is appropriate. That can take a little bit of time. I think usually I'll say a couple of months at least to transition, slowly wean off one, start new medicine, address if one medicine's enough, if we need another, and assess for side effects, and then switching agents if we need to. So it's a little bit of a process, but it absolutely pays off later on. And I think that's one of the biggest things we can say is just like setting yourself up ahead. It's totally doable. I have many patients who had maybe in their first pregnancy a little bit of a tougher time with their blood pressure, but then we work on their blood pressure afterward and set themselves up for the next pregnancy. And they go through great. The second thing I would also say is making sure that we're at a really ideal weight before, because that also plays into your blood pressure as well. And even, a couple pounds difference, 8 to 10 pounds weight difference can really affect your blood pressure. So it's still worth it. We're not asking for something extreme before. We want these little controlled changes that you can maintain. So I think that, there is fear, and I think a lot of anxiety going into it again, knowing that this happened before, but we should use it and learn from it and then empower ourselves for moving forward.
That's excellent. I'm so excited, just with having this whole conversation because it's so important. I think that, one of the things that we talk a lot about is, family history. And, sometimes I hear a family history that really kind of raises my eyebrows, and I say, okay, let's have you evaluated. And also, discuss with the cardiologist so that we can make sure that this isn't something that could potentially affect you or your future family. And so, when I hear early cardiac death, or someone who's had a major, cardiovascular event, at a younger age, less than 50 or 60, then I definitely, want to send them your way as well. What kind of things do you listen for in the family medical history as you're gathering that information that could be really important insight into that person's own their own health?
Absolutely. We definitely want to look into their family history because it gives us a clue about what some of their own genes maybe have in store for them in the future, and things that we can actually take intervention on. So one of the things I think that you cannot underestimate is uncontrolled hypertension or hypertension that occurred early in their family members. That is something that can be helpful, not just to raise our own awareness, but also to give some comfort to the patient, knowing like, you are doing your best. It might just be your genetics. It might be something familial, and that's okay. I think sometimes that kind of frees up the guilt and the onus on the patient, knowing like, not in your genes, it's okay. So I like to always ask about that. Also sudden cardiac death, absolutely, or arrhythmic deaths that were, not to sound morbid, but things that are unexplained all of a sudden in younger patients who are relatively healthy. Those are things we should know about, not only for screening the patient, but also for saying, hey, screening the patient, maybe then we need to screen the baby later on. Valvular disease in family members. So sometimes there's inheritable valvular problems that can run in families that then we want to screen the mother for prior to conception. It lets us know, hey, valves are looking great. There's no issues with any type of anesthesia you might need, natural delivery, or, this valve is looking a little bit stenosed, or this valve is looking very leaky. What does that entail in terms of actual pregnancy and then delivery itself? And then the final thing is sort of looking at coronary disease. Coronary disease, super prevalent in Western countries, partly because we're more sedentary and our diet is not so great. So we want to start seeing, being more aware of these alarm bells. Family members having early heart attacks, early strokes, less than 50 for sure, 40 in men. But in women specifically, we're protected by our estrogen up through menopause. So if you're hearing 50, that's pretty early for women. So those would be things that give me alarm bells and say, okay, this patient, we should be even more aggressive controlling their blood pressure, their sugars, their cholesterol, and then screening for premature atherosclerosis. And that can be as simple as just checking an ultrasound of the carotid arteries to see, hey, do we have plaque at this cholesterol level? If we do, is that as much as we would expect to see? Is it more? And then should we be targeting lower cholesterol levels because of it? So those are sort of the things that we normally look into when we're talking about family history with patients.
That's awesome. I want to talk about two more things. So one, we're very focused on, preventing cardiovascular disease in the long term and also anything that may present during pregnancy. And so one thing that I'm always very kind of cautious about is how can I potentially reduce the risk for preeclampsia in pregnancy? Sometimes patients will come with a history of preeclampsia. Many of my patients may not have been pregnant before, but also actually have preeclampsia risk factors, including having never had a successful pregnancy, their age, sometimes extra weight or things like blood pressure. But even, that almost describes many of my patient population in terms of, having their first pregnancy over age 35 and not having had a pregnancy before. So what are some ways that we can, potentially reduce the risk for preeclampsia in pregnancy?
Yes. So I know I'm really repeating over and over. I think it's just engaging in your healthcare early and not we have this tendency, we're healthy, we're super busy, we're young women who are like trying to do family life, but also work on our careers and be busy and be up for our promotions. And so I think a lot of times our own health takes a little bit of a backseat to that. And we don't always see our physicians. We cut back on, doing that meal prep or doing our exercise. And I think that's one of the biggest problems is just the setup is not there. And so all of that work you do ahead is going to help to prevent preeclampsia. That's my biggest thing that I would say. It's just setting yourself up. If you're thinking, maybe I would be interested in starting a family in the next 5 years, these are some things I would start. And it's never too late to start working on it. You should never feel like, oh, I'm too far gone. Like, I don't know how I'm going to get this under control. It's never too late. One of the biggest things that we see in preconception, conception, pregnancy, postpartum, and then your long-term life is that anytime you make an intervention, you are changing that future downstream and you can make a difference there. Obviously earlier the better, and we do see signs of that, but even during pregnancy when we catch, I had hypertension diagnosed in pregnancy, that is a time point that you can say, okay, now we can change this woman's life. We can change her cardiovascular health for the future, because those women are at higher risk of heart attack, stroke, heart failure, kidney disease, vascular problems in the future. And it tends to happen earlier for those women who have had those issues during pregnancy. So that's another thing when patients come in to see me and they say, you know, I have hypertension now. How do I look through my long-term health? I always ask, how are your pregnancies? Did you have preeclampsia? Did you have gestational hypertension, gestational diabetes? It just gives me a marker to say, hey, be more aggressive. This can happen earlier. You need to not just accept a 140/80 blood pressure. We need to do better. We need to start screening carotid arteries. We need to start thinking about calcium scoring for coronary calcification. And we need to work on weight loss and exercise. I think it's really, for me, it's like, it's just a continuum. You have to think like early targeting this to prevent it from happening. I know, and you can speak to this, like the aspirin studies have been very encouraging. I myself took aspirin during my recent pregnancy, and that, you know, gave me a lot of comfort knowing that that was one thing I could do in addition to my regular lifestyle changes that I was doing. But I think the more you set yourself up, the better you're going to do later. And each step is a chance to fix the next stage of life and to set yourself up for that next stage. You know, and I think taking that time and space to do that for yourself is really, really important.
It's so important. Thank you for that. You know, I think one of the final things I want to just talk about is diet. You know, when we talk about kind of like a heart healthy diet, there's so many different sources, and we know patients are, you know, increasingly getting a lot of their information from social media, which may or may not be accurate. You know, when you talk to patients about, okay, this is the diet I want you to have to, you know, benefit your cardiovascular health, what does that include? What does that look like?
It's so hard now. It's like, yeah, heart healthy diet. That seems very intuitive. It's not always, especially as you suggest, given that there's fad diets, there's new things coming out all the time. And everyone hears about these things and says, well, this is helpful for weight loss, or this is helpful for glycemic control. Really, what we think of is the DASH diet and the Mediterranean diet. Those two intersecting usually gives you the best cardiovascular health. And so what we mean by that is watching your salt intake, trying to stay under 2 grams of salt in the day. And just thinking about the Mediterranean diet, it's really focusing on those fresh vegetables and fruits, lean protein that's not high in saturated fat, and then your low saturated fat dairy options. So it's that saturated fat that's in your red meat, your processed meat, most of your processed foods, whole fat dairy and cheese and yogurt, that can then clog those arteries over time. And obviously the lean proteins like chicken, like fish, pescatarian diets are excellent. Those things really don't tend to accelerate your atherosclerosis. So that's generally the type of diet we're talking about. The more you shop around the outside of the grocery store where there's less processed things and there's more fresh grains, fresh produce, both veggies and your meats and fish, the better you are. The more, when you look at that ingredient list, that there's a long stream of things, it's probably not going to be the best cardiovascularly. And then trying as much as you can to replace whatever fluids you're drinking with water. Usually you're going to lose a lot of empty calories by not just drinking those sweetened beverages. So that's generally what we recommend. Low saturated fat, lots of fiber, and then low saturated fat, not just in your protein, but also in your dairy.
No, that's so important to remember. Well, I love that we're able to have this collaboration. I think that you are such a gem and a credit to have
Oh.
to patients. And I always like working with, you know, my genetic counseling partners, cardiology, internal medicine partners, and just always remembering that we're taking care of a whole person. So, you know, so much of what we focus on is getting to baby. but making sure that we are considering, each individual as a whole person who wants to be healthy for their whole lifespan, including being available, for their child and for their family later on. Well, please let us know, how can we find you and how can patients, come to see you?
Yes, absolutely. So if you go to my main Mount Sinai webpage, that's the easiest way. It has all 3 office locations. And then there are scheduling options online, as well as you can call in and you can see your options of which office is closest and easiest for you. I do in-person visits as well as video visits, and we have some Saturdays as well, because we know that working moms, working future moms need a little bit of extra time, and sometimes the weekend is best. And we're happy to see patients at any time to work on our mutual goals, and just looking forward to more collaboration. I love our patients together. We have some of the best patients that are so sweet and so motivated, and they just want it all. And I think I love hearing that. So I'm like, I want to give you everything. Let's do it.
Yes, I agree. Let's do it. Well, thank you so much for joining us today. And we're so excited to share any information that we have about cardiovascular health, about the intersection between cardiovascular and reproductive health, with all of you. So thanks so much.
Thank you for having me.
All right, Hannah.